ma'am.
Hello sir, how are you?
Good afternoon, how
Good
are you?
afternoon, sir. अब डिसऑर्डर की बात करें तो ये तो बताना पड़ेगा ना
बताना
क्या
पड़ेगा
कर रहे
थोड़ा
हैं।
सा, एटलीस्ट तो नाम तो लेना ही होगा ना मैम, बताना।
वन एलिमेंट चाहिए होगा आपको।
सेम थोड़ी ना करना है
सेम
सब
थोड़ी
में।
करना है।
आपने देखा होगा नेहा मैम और मीनाक्षी
हाँ तो
मैम वो
लिपस्टिक
चीज़
लगा रहा है,
आगे।
हम थोड़ी ना लिपस्टिक लगाएंगे ना।
अरे ये नेचुरली है ये इसी को नेचुरली कहते हैं। चाय पिला दो।
अभी है ना, चाय
चाय लेके आओ, चाय लेके आओ।
चाय तो आगे सर।
चाय पिलाओ यार, चाय पिलाओ।
एक बार में नहीं होगा, मेरे को दोस्त चाहिए।
सर आप मेरा बर्गर
Hello student, I am Dr. Soumen Manna, your physiology teacher.
Hello friends, hi, I'm Dr. Shonali Chandra. Basically, we want to talk about the core concepts.
Start हो गया। हाँ,
अरे ये स्टार्ट नहीं हुआ क्या?
Start
अभी
नहीं
सब
हुआ,
हो गया
हाँ।
खत्म।
मैम थोड़ा मॉर्निंग करो, ठीक है मैम।
क्या बकवास कर रहे हो? इतना आपने रिकॉर्ड किया, कैमरा ऑन नहीं था।
नहीं
तो
ये
तुमने
तो
बीच में बदले झूठ
नहीं
बोल
नहीं ये झूठ बोल रहा है।
बीच में पता नहीं चलेगा तुम्हें।
वही।
Hello friends, hi, I'm Dr. Shonali Chandra, your Ops Gynae faculty.
And I am Dr. Soumen Manna, your physiology faculty.
So we've decided that today we're going to talk about abnormal uterine bleeding patterns, right? Now, we want to discuss the core clinical concepts regarding abnormal uterine bleeding patterns. And to dive into the core clinical concepts, first of all, it is very important that we deal with the basic physiology of the menstrual cycle. So I'll let Dr. Manna take over from here.
Right. So whenever we say about menstrual cycle, you know, it's basically a cyclical events which is happening in the female reproductive tract in every month. And we know the interval of this event is on an average 28 days. That is a perfect cycle duration. So what events are happening within this female, reproductive tract? You know, there are certain changes which is happening inside the uterus. That is known as the uterine cycle. And parallelly, there will be certain changes happening inside the ovary, which is basically known as the ovarian cycle. So what will happen inside the uterus? All of you know that this endometrium which is there inside the uterus, there will be shedding of the endometrium, that is known as the menses, followed by this endometrium which has been shedded up, that will be regrow, and then that secretory changes will happen inside the endometrium. So that is the part of the uterine cycle. And inside the ovary, parallelly, certain changes will happen. What are those changes? That is the development of the follicle inside the ovary. That you can see here in this diagram, that different stages of the follicles are there inside the ovary. So that is known as the follicular development phase. Then when the follicle is fully mature, then the ovum will be released from that follicle. That is known as the ovulation. All of you know. And after the ovulation, what will happen? This ruptured follicle will be converted into corpus luteum. That is known as the luteal phase. So in respect to ovary, what is happening? First, the follicular development is happening. That is the follicular phase. Then the ovulation is going to happen. And after the ovulation, the corpus luteum is formed. That is the luteal phase. So with this respect, if you look at, then you will understand that the menstrual cycle means certain changes is happening inside the uterus. That is known as the uterine phase. And certain changes are happening inside the ovary. That is the ovarian phases. Now, Madam will also tell later on the disorder of the menstrual cycle. There you will understand that the menses, that is the actual shedding of the endometrium, that is generally from day 1 to day 4. That is the bleeding part. That is the menses, right? After that, there will be proliferation of the endometrium. That is generally from day 6 to 14. And after that, there will be secretory phase. Now, if you correlate these changes in the uterine phases with the ovarian phases, then you will understand that this menstrual phase and the proliferative phase, they correspond with the follicular development phase inside the ovary. Means when the menses is going on inside the endometrium and the proliferation of the endometrium is going on parallelly inside the ovary, the development of follicle is happening because the ovum has to release from the mature follicle. That's why this follicular development is needed. Now, whenever the follicle is fully matured, the ovum is going to be released from there, and all of you know that is in normal menstrual cycle that ovulation occurs in and around days 14, right? And after that, whenever the ovulation happen, that the rupture follicle will be converted into corpus luteum, that is known as the luteal phase. Now this corpus luteum produces huge amount of progesterone that we'll be discussing in the next slide. But because of the progesterones and the little amount of estrogen, what will happen? There will be certain changes in the endometrium, and that changes is known as the secretory endometrium. That's why that whenever this luteal phase is going on inside the ovary, that the corpus luteum is developed. In that time, what is happening inside the endometrium? The secretory changes will happen.
So what we're trying to say here,
Right.
sir, is that the ovarian cycle is
Right.
actually driving the endometrial cycle.
Great.
Right. So the events that are happening in the ovary, those are responsible for at the
Exactly.
same time what is happening in the endometrium cycle. That is
Right.
the gist
Right.
of
Right.
this physiology.
And now you'll understand this thing which ma'am said in a better manner in this slide. So first of all, you try to understand the same thing, right? So we have discussed that the ovarian phases, which is happening inside the ovary, and what are the different ovarian phases? The follicular phase is there, followed by luteal phase is there, and in between there is ovulation, right? That is in and around day 14. And again, after the luteal phase, again the next cycle is going to start from here, that is the day 28. Parallelly, I told you that there will certain changes. Ma'am told that the ovarian phases is going to drive the uterine phases. So what are the different uterine phases? The menstrual cycle, that is the actual menses, followed by the proliferation of the endometrium, followed by the secretory changes in the endometrium, and again the next cycle is beginning from here. Now during these two things, what is happening inside the ovary and what is happening inside the endometrium? As you can see here, this is the ovarian event. What you are finding out here? The follicle is developing, then the ovulation is happening, and the follicle is turning into a corpus luteum. And parallelly, what you are seeing here in the endometrium, first there is shedding of the endometrium, that you all know, that is the menstrual phase, followed by the endometrium is growing, that is the proliferation, and then a constant thickness of the endometrium is persisting, and that is your secretory phase of endometrium. So we will try to understand that how this is happening. Ma'am already told that the ovarian cycle is driving the endometrium cycle. So that we are going to discuss here.
And I also want to point out one more
Right.
thing, that day one of the cycle by convention we take as the day the bleeding starts.
Right.
Right. And also important thing to note here is that
Right.
the duration of the luteal phase is the one that is fixed here. That is 14 days. And that's because, when the corpus luteum forms, the
Right.
lifespan of the corpus
Corpus
luteum
luteum.
is constant.
That
right?
is a very important thing that you have to
so
remember.
in a woman who is having a menstruation, right, and like in the non-pregnant state,
Right.
the lifespan of corpus luteum is about 10 to 12 days.
Exactly.
So it will automatically, after it finishes of the lifespan, we'll say that luteolysis happens. We'll talk about later, and that is when the hormone withdrawal takes place. So the
Exactly.
luteal phase by convention we take duration fixed as 14 days, and that's why we can say that it is
Yes.
on the 14th day that ovulation takes place in a woman who's having regular 28 day cycles, right? So that in gist would mean, supposing somebody is having longer cycles,
exactly.
instead of 28 day cycles, 35 day cycles, right? Even in those 35 days, if she's having regular 35 day cycle, the luteal phase, the
Phase
second
will-
half of the cycle will be 14 days.
Right.
And the duration of the follicular phase is what changes.
Very,
right?
very important thing.
So we
that
can, that way is in retrospect, kind of, predict the day of ovulation, roughly, yes?
Exactly.
Predict the day of ovulation in a woman who's having regular cycles.
Right. So now let's see how this is happening. So whenever the follicular development is happening inside the ovary, the question will arise, who is developing the follicle, under which influences? And that you have to remember that under the influence of FSH and LH. So these two hormones have their receptor on this follicle on different cells, and with the acting on those receptor, they are helping in the development of the follicle. But during this development of the follicle, this growing follicle is going to produce one important hormone, that is huge amount of estrogen. So please remember that during this follicular development phase, the dominant hormone that is produced by this developing follicle is estrogen. And under this estrogen, what is going to happen? I already told you, madam also told you, that proliferation of the endometrium is going to happen. Along with that, you also have to remember there is another hormone here, that is inhibin B, right ma'am? This
Yes.
is also important for their MCQ.
Yes.
Right. So this estrogen is causing proliferation of the endometrium gradually. And parallelly, what is happening inside the ovary? The follicle is getting more and more matured. Now,
So when we talk about maturation
Right.
of the follicles, if you look at, just kind of zoom into the follicle structure, right?
Right.
There are granulosa cells and there are theca
Theca
cells, right?
right?
So granulosa cells are the ones which are producing more and more and more amount
Exactly.
of estrogen,
Exactly.
right? So as the follicle becomes larger, the number
So-
of granulosa cells around,
Yes.
increases dramatically, and that
Yes.
is responsible for this huge amount of estrogen
Right.
production. As
Right.
Sir pointed out, inhibin B, that's also coming from the granulosa cells
Yes.
only.
Yes.
So you can remember it like this, that it is the granulosa cells which are responsible for both inhibin B and estrogen production at this point in time.
Now you try to understand here. This ma'am told inhibin B. So this inhibin B has a negative feedback effect on this FSH, and the estrogen, as also progesterone, they have a negative feedback effect on LH. But the thing is that ma'am already told you that when the follicle is growing more and more, because of the granulosa cell volume is huge, becoming huge, what happens? This estrogen level in the blood rises to a very, very high level, more than 3 times than that of the normal blood. And it is said that whenever the estrogen level in the mid-cycle rises at least 3 times more than normal, and if that high level of estrogen persists for at least 2 days, then what will happen? This conventional negative feedback effect will be converted into a positive feedback effect by changing the sensitivity of the hypothalamus and pituitary. That means what I'm saying, yes ma'am, if you want to add.
So this is interestingly very unique
Very, very
thing
unique.
that happens
Right.
in the menstrual cycle, where estrogen can have like a dual effect
Right,
on LH,
right,
right? In the first part
right.
of the cycle, it is inhibiting.
Yes.
And then when a certain threshold level
Exactly.
is crossed for a certain duration of time, the switch in feedback signals
Right,
happens from
right.
negative to positive. This positive feedback mechanism actually is the key which will drive
Exactly.
ovulation, as we will see.
So you have to remember that throughout the menstrual cycle, this estrogen and progesterone has negative feedback effect on LH. But when the estrogen level is very high, particularly in the mid-cycle time period, and if it is persisting for more than 2 days and particularly a certain level, threshold level, then what will happen? This feedback on LH will be converted into a positive feedback. And all of you know that whenever this feedback is turning into a positive feedback, huge amount of LH, will be produced from the pituitary, and because of this LH, what is going to happen? The LH surge is going to cause ovulation, right? So that is the most significant event here. So the ovulation is going to happen. And whenever the ovulation happens, what will happen? This rupture follicle will be converted into corpus luteum. There will be growth of blood vessels inside this rupture follicle. And because of the growth of this follicle, what happens? The corpus luteum will be converted. Now this corpus luteum is maintained under the influence of LH. So this LH, which is already high because of this positive feedback, now it is going to stimulate the corpus luteum cell, particularly the granulosa and theca cells. And because the corpus luteum is stimulated by LH, what is going to happen? The corpus luteum is going to produce huge amount of progesterone and little bit of estrogen. So that's why there was an MCQ. I think, ma'am, there was an MCQ that who maintain the corpus luteum? Corpus luteum produces progesterone, but maintenance of the corpus luteum is done by the LH.
In the non-pregnant state.
Exactly. So look at the sequence. So the estrogen is giving LH surge. LH is high, that is causing ovulation. After ovulation, corpus luteum is formed, and that corpus luteum is maintained by LH.
Yes.
Now, under the influence of LH, the corpus luteum is producing huge amount of progesterone. And this progesterone is going to act on the endometrium, and the endometrium will be converted into a secretory activity, right?
And one thing also very interesting here is that estrogen, we are saying that it primes the endometrium for
Right,
progesterone action. That is very, very important. I mean, the sequence of events will be in this order. Estrogen will build up the endometrium first, and progesterone will then stabilize the endometrium, right? So under the influence of estrogen, otherwise, the endometrium will keep building up, but we need to stabilize it, and that's very, very important. And another interesting thing is, these secretory changes which happen because of progesterone, why are they happening in the first place? Let's so to say, this is an anticipation of a pregnancy.
Exactly.
Because once there is a pregnancy, it will come and implant on this prepared endometrial lining, and secretory changes are very, very important in that regard.
Exactly. Okay. So now, whenever the endometrium has been converted into secretory changes, now you try to think of. So this progesterone, what will have this progesterone and estrogen? What kind of effect, feedback effect is there on the LH? I already told you that throughout the menstrual cycle, this progesterone and estrogen has negative feedback effect on LH. So initially, this LH is helping the corpus luteum growth, and the corpus luteum is producing huge amount of progesterone. Now this progesterone or estrogen is giving negative feedback to the LH. So what will happen? The LH level will decrease. Now whenever the LH level decreases, what will happen to corpus luteum? That is maintained by LH. If the LH is reducing, so obviously the corpus luteum is also going to die. Means there will be regression of the corpus luteum gradually. And whenever the corpus luteum is regressing, what will happen to the progesterone level? The progesterone level will decrease. And whenever progesterone level decreases, as ma'am told already, that it is the support to the endometrium. If that support is lost, what is going to happen? Again, the shedding of the endometrium will start, and that is known as the menstrual cycle. All of you know. So please remember this sequence of events, how the hormonal changes is building up the endometrium, and parallelly how the changes is happening inside the ovary, right? So now if you look at that, how this decreased progesterone is causing the shedding of the endometrium, or if you can understand what is the mechanism of menstruation, that is also required to understand the pathology also. So I already told that first of all, there will be regression of the corpus luteum. Because of the regression, the major hormone that is going to be reduced is the progesterone. Also the estrogen level is also going to reduce. But whenever this progesterone is reduced, you know that the production of the PGF-E2 and PGF2 alpha will be there. There will be huge production of this prostaglandin, because you know this progesterone is basically an enzyme which inhibits the COX-2 enzyme, as well as is also prevent the lysis of the cell, the lysosomal enzyme. So whenever
that's very interesting. Yes, the progesterone. We just said that progesterone stabilizes the endometrial lining, right? So what it means is that it stabilizes the lysosomal membranes, you know, and once the levels of progesterone come crashing down, that is when the lysosomal membranes will break down, and these enzymes
so
and prostaglandins
membrane will break down, plus the membrane phospholipid will be converted into prostaglandin under the influence of COX-2, because progesterone normally inhibit the COX-2. Okay, so because of which huge amount of this prostaglandin will be produced, and these two prostaglandins are very important for MCQ. Now this prostaglandin is going to causes vasospasm, vasoconstriction of the spiral artery which was there in the secretory endometrium, and whenever this spiral artery is getting spasm, what will happen? There will be ischemia, there will be necrosis of the endometrium. So focal necrosis will appear in endometrium, and that necrosis will coalesce with one another, and that will leads to the bigger necrosis on the superficial part of the endometrium, and that will leads to shedding of endometrium, hemorrhage, and that is actual menstrual bleeding, and obviously the pain is also going to happen.
Yeah, so another very interesting thing, like you know, so you'll have to pick at the important pointers from these flowcharts. Like for instance, I was saying that there's vasoconstriction of the spiral artery. Now this is very crucial. Spiral artery typically, because spiral artery is supplying the superficial 2/3 of the endometrial lining, right? And these are end arteries, right? And they respond to hormonal fluctuations like this. So that is the reason why, you know, it is the superficial functionalis layer, the superficial 2/3 of the endometrial lining, which is going to break down and is going to shed off as menses. Also importantly, all this enzymes, you know, like this PGF2 alpha and PGE2 and other cytokines are also released, which sort of, let's say, enzymatic auto-digestion of the endometrium is taking place. And then the other question is, what stops the bleeding? Okay, the bleeding did start, the shedding did start, but what stops it? So this very same vasoconstriction, you know, is going to initially also lead to decrease in the blood flow, and ultimately new endometrium has to be regenerated. So we'll call it as reepithelialization of the shedded endometrium, and that will happen from the basal layer of the endometrium, the deeper 1/3 layer. So basalis layer is not shed off. That is going to help regenerate the new endometrial lining, and the basalis endometrium is supplied by the basal artery, which are not end arteries. They don't respond to hormonal fluctuations, right? So we kind of correlate how beautifully the anatomy is designed by nature. You know, that we have two layers, we have two distinct, and we have two distinct patterns of blood supply to these linings, and that's how it is brought about each and every month, you know.
Exactly. So now, if you look at the amount of normal bleeding during the normal menstrual cycle, this is also required subsequently. So this is approximately 40 ml. Ma'am will add on later on. Along with that, you have to remember that menstrual fluid is normally non-clotting because of the presence of this fibrinolysis. But all of you know that certain clots can be present even in the menstrual bleeding.
Yeah, but if a woman is passing
Yeah,
excessive clots,
Right.
that's not normal. That's
Yeah.
considered heavy. Because see, another thing that will help with the stoppage of bleeding, I mentioned two things: vasoconstriction and reepithelialization. Other than that, the normal clotting mechanisms of the
Exactly.
body also. But if she's bleeding heavily, right, then the clotting mechanisms will will be consumed excessively, right? And then yes, more and more clot formation and passage of clots should not be considered as normal pattern.
Right. Now we have already understood the different changes which is happening in the ovary and endometrium. So now this will be easier to understand the level of the estradiol and progesterone and LH and FSH, how they are fluctuating during the normal menstrual cycle. So here you have to understand that in this diagram, the x-axis, the day 0 has been given. But ma'am already told that the menses, that is the starting of the bleeding, should be taken as day number 1. So that's why, as you can see here, the ovulation that has been shown here, this is generally days 14. But here it is showing generally 13 because it is starting from 0. But other things are very, very normal. So we have already discussed that during the proliferation phase of the endometrium, right? So what is happening? The follicular development is happening inside the ovary, and that is rising the estradiol. Now, I already told you that estradiol has negative feedback effect on which hormone? That is the LH hormone. So initially, it will give the negative feedback effect on LH. And parallelly, I also told you that the initial part, there will be secretion of the inhibin B hormone, and this inhibin B hormone has negative feedback effect on FSH, right? But also I told you that whenever this estradiol is very, very high, particularly above a certain level, and if it is persisting for more than 2 days, then what is going to do? It is going to cause positive feedback on LH, and because of which this is the LH surge that you can appreciate. And whenever LH surge happens, the ovulation is going to happen after that, and after ovulation the corpus luteum is going to form. This corpus luteum is going to produce huge amount of progesterone, as well as is also going to produce little amount of estrogen. And I told you this estrogen and progesterone, they have normally the negative feedback effect on LH, so LH will suppress, right? But in the second part of the menstrual cycle, the inhibin A is also going to produce, and that will have a negative feedback effect on FSH. So because of which this negative feedback, the LH and FSH level will also decrease. And whenever this LH level is decreasing, I told you already that the corpus luteum is not going to maintain, the corpus luteum is going to regress, and the progesterone will also decrease. And because of which, again, the menses will start, or the shedding of the endometrium will start, right? So this kind of diagram generally given in MCQ. So you have to remember how this hormonal level is fluctuating.
And you also remember a lot of things from this chart itself, a lot of concepts. Like what you need to keep in mind is that the function of inhibin here is to inhibit FSH, right? And remember that the source is different when, in the two halves of the cycle, and this becomes an MCQ. So inhibin B, like we discussed earlier, is coming from the granular cells, and inhibin A is coming from the corpus luteum, right? So this is very interesting. The other thing is very, very important to note here is, the estradiol peak, as we call it, this fluctuating level of estradiol. So earlier they are, tend to rise, but they're not yet there. And then they rise dramatically. Now this dramatic rise of estradiol, we're calling this estradiol peak, is happening because of the dominant follicle, right? And one analogy I would like to give you to help remember. That it is so, again, nature is so beautiful, right? The fate of the dominant follicle as to what will happen to the dominant follicle, whether it will ovulate or whether it will not ovulate, the control is with the dominant follicle. In the sense, like a good dominant follicle, rich, producing the adequate amounts of estrogen, will be able to ovulate, right? So that control has been given to the dominant follicle itself. So there's certain interesting things here, that, and all this is brought about by nature to do what? To have a regular, cyclical, timed ovulation.
Exactly.
And that's all these nitty-gritties regarding the cycle are directed towards one goal to achieve, and that is to achieve a regular timed ovulation. And because ovulation timing is so strictly controlled, and that is why the cycles are regular, because ovulation occurs regularly at a regular timed interval, right? And the other thing is this rising and falling of estrogen, the surges when we call
Exactly.
it. When we define something as a surge, means it is first at a lower level and then increasing
suddenly,
and then
yes.
falling down again.
Yes.
So this cyclicity, this pattern is what is important for ovulation to occur. For instance, if there were chronically elevated estrogen levels, right, at any level, at a
Right,
low
right.
level or at a high level, chronically elevated, surges are not happening. The rise and fall is not happening.
Exactly.
And ovulation will not occur.
Yes.
Right, so surges is important.
Very, very
Chronically elevated LH levels for some pathological reasons, right? Like we tend to see in polycystic ovary syndrome also. Chronically elevated LH levels. They're not, following the typical pattern of surges. Then ovulation will not occur.
Right. So now if we summarize this whole thing from the hypothalamus up to the level of this ovary. So hypothalamus is producing GnRH. There will be pulsatile secretion of GnRH at an interval of 90 minutes interval. So this pulses is very, very important for the secretion of this FSH and LH. And this FSH have the receptor particularly on this granulosa cell, and the LH has the receptor on theca cell mainly. And under the influence of this LH, the theca cell is going to produce androgens that will be diverted to the granulosa cell, and with the help of an aromatase enzyme, this granulosa cell is going to produce progesterone and estrogen. A little amount of estrogen and progesterone will also be produced by this theca cell. So here it is not shown. And I told you that throughout the menstrual cycle, this progesterone and estrogen, they have negative feedback effect on hypothalamus. Only just before ovulation, this negative feedback effect will be converted into positive feedback. Otherwise, this activin and inhibin is also produced by this granulosa cell, and the major effect of this inhibin is the negative feedback on this FSH, and the activin is the positive feedback effect on FSH. So this is the whole control system, how this hypothalamo-pituitary ovarian axis is controlled.
Now, one clinical pointer that I would want to drive from this flowchart is, let's understand the basic clinical concept here, is that granulosa cells are predominantly forming estrogen, right? And we have theca cells, right, which are predominantly producing androgens.
Right.
So this is basically what we call as the two-cell, two-gonadotropin hypothesis, on which also, again, when you reach your final years and when you start reading endocrinology or gynae endocrinology in greater depth, then you tend to, grasp or relook at these concepts again. So we have LH, that is the gonadotropin, theca cells, the other cells, and they're producing androgens, right? So androgens are always the raw material for estrogen synthesis. I mean, this is basic biochemistry, right? From steroid synthesis, androgens will always lead to, estrogen production will always happen from the raw material, which is androgens. Yes. It doesn't happen the other way around. Right? So estrogens don't convert back to androgens. Right. It's androgens that convert to estrogens, right? So androgens are important as far as estrogen production in the normal menstrual cycle is concerned. But if for some reason there is excess of androgens in the ovary, like we see in polycystic ovarian syndrome, if the ovary starts to, if the environment become androgenic, let's say ovary is producing more and more of androgen, then that is detrimental, that's problematic. Then the follicular growth will not happen properly, or follicular growth may even be suppressed. And again, ovulation will be hampered. So that is one important pointer. Secondly, if you look at if you kind of zoom out from this flowchart, right, and then you look at broadly, the control from the hypothalamus and pituitary is also equally important.
Exactly.
So if for some reason any pathology or any hormonal fluctuations which is leading to suppression of the axis from right at the top, right? Yes. Like for example, if it happens during stressful times, right? Very peculiar, like stress of exams, stress of a breakup or whatever, excessive weight loss, exercise induced, anything that suppresses the axis from top will also inhibit ovulation, because follicles will not grow. And growing of follicles is extremely important to achieve a dominant follicle eventually, right? So that's also equally important, and something very physiological that we see when, women age reproductively, right? Like in the perimenopausal age group, right? The number of follicles that are remaining in the ovaries, those are declining, right? So they're not able to produce enough estrogen. They're not able to produce enough inhibin. A cycle gets disturbed, and we have anovulatory cycles in the perimenopausal age group. And eventually, when the cycles will get over, that is when menopause will happen. That's because the source of estrogen is not there completely. All the ovarian follicles are depleted. And if there's no estrogen, there is no endometrial proliferation at all. And that leads to physiological suppression of menses, that is menopause, we call it,
Right.
right? So coming now to the abnormal patterns, right? And let me point out one more thing, first of all, to the students, right? Your basic core physiology of menstrual cycle is the most important thing that you will learn, right? All gynae disorders, any pattern of abnormality will revolve around your understanding of the physiology, most importantly, right? So talking about the abnormal patterns, this is what we have from abnormal uterine bleeding pattern given by FIGO. This is system 1, right? It's basically a system to so that everybody calls or describes a menstrual cycle in the same manner.
Exactly.
Right, so a homogeneity of description is there basically, right? So when we take a menstrual history from a woman, we ask, how frequently are your menses coming? Are they coming at a regular time or not? Right? How many days do you bleed? Are they regular or not? Right? And how much is your bleeding that is happening in your menses? Right? So frequency, duration, regularity, flow, volume. These are the 4 typical points we take in history, right? So normal is anything between 24 to 38 days, right? We'll call it frequency, frequent. That is how we're going to define it. I'm having regular cycles, normal cycle length, or I'm having periods coming every 21 days or every 15 days, right? So that would mean more frequent periods in a year. So this is what we used to call as polymenorrhea. Poly, more menses in a year, right? Similarly, if she's having infrequent menses, right? Like, for example, she's having periods every 2 months instead of every 28 days, right? Or instead of that, every 2.5 months or every 3 months, like that, right? Then she's having less periods in a year. Less, oligo, right? So we call it as oligomenorrhea. So that is what we call as delayed cycles. So frequent menses would mean short cycles, right? Because you find these terms confusing, you want to mug up what these terms are. So frequent menses meaning short cycles and infrequent would mean delayed cycles, right? Then we look at the duration of the menstrual blood flow, right? Normal is anything which is less than or equal to 8 days. So the normal range is generally taken to be as 2 to 8 days.
Right.
On an average, women bleed about 4 to 5 days. That's
yes.
average, right? But we're talking about when to start investigating or when to consider abnormal. So prolonged duration of bleeding is not normal, right? And if you look at the regularity, exactly 28 days cycle, not every woman has. Okay. And even somebody who's having 28, sometimes it's 28, sometimes it's 27, sometimes maybe 29. So a little bit here and there often happens, right? But we would call it regular when the in cycle to cycle variation is less than 7 to 9 days. But if it is more than that, more than 8 to 10 days, we'll call it as irregular cycles, right? This is what was previously called as metrorrhagia. Right. Now, these are older terminologies, they are actually discarded more or less in clinical practice nowadays, like we want to describe the menstrual cycle pattern, whether it is irregular or falls under regular cycles. But yes, irregular cycles was previously called as metrorrhagia, where there is no pattern. Sometimes it would come in 15 days, sometimes a month, sometimes 35. So she cannot predict when her next period would come. Let's put it like that, right? And then flow, volume. Whether it is normal, whether it is light, whether it is heavy, that needs to be described. Now, who describes this? This is patient perception. A woman's perception of her own bleeding is the most important aspects, because over the years, women tend to recognize their own pattern. And then any change from her own pattern is what is important, right? Because flow volume is something which becomes very difficult to quantify, right? Yes. So we have those definitions. Heavy, we would say more than 80 ml, in amount. And or duration, duration which is more than 8 days, we would have called it menorrhagia. Again, this term has been discarded, right? Because again, it's very difficult to quantify ml wise, blood loss, right? So it's patience or perception that is very, very important. And again, passage of clots would be a very, very important pointer towards heavy menstrual bleeding, right? So we have these two terms. One is intermenstrual bleeding and one is heavy menstrual bleeding. Intermenstrual bleeding would mean that there are acyclical bleeding episodes. I mean, they can come randomly anytime during the month, or in the month they may happen at some regular timed interval. Like sometimes women tend to have a little bit of scanty bleeding during ovulation time also. But important thing is that superimposed on normal menstrual cycle. So she's having a periods usually normally, but in between somewhere in the month, she may bleed for a couple of days like that. That bleeding may be heavy. that bleeding may be scanty, right? Or just spotting, like, so that depends.
So is that normal, ma'am?
No, it's not normal.
Okay.
Intermenstrual bleeding is something that is also very specific.
Okay.
It is pointing towards maybe some focal pathology in the endometrial lining particularly. So this is a very
So you have to investigate that.
yes, this is a very typical finding or a typical complaint.
Okay.
Then heavy menstrual bleeding, how do we define heavy menstrual bleeding? So like I said, menorrhagia we used to call it. It used to say that either in amount or duration and or duration, right? Now with the clinical practice, we have to understand that any amount of excessive bleeding which the woman says is interfering with her physical, social, emotional or material quality of life should be considered heavy, should be considered important enough to investigate. So woman's perception, again coming back to it, is very, very important.
So mainly this is clinically more important.
Yes. So this
physiology.
Yes. So this description or this description of abnormal uterine bleeding patterns is not something that is different from what we day in and day out practice in the OPDs. These are the 4 questions we ask the woman, right? Regular or not, right? What is the cycle length? What is the duration of flow? What do you perceive? Do you think it is heavy? Do you think it is light? What was your usual pattern? Is there a change from your usual pattern? You ask these 4 points in history and you describe the very same findings, and then you decide, is it an abnormal pattern for this woman or is it a normal pattern for this woman, right? So whenever you have abnormal uterine bleeding pattern, broadly speaking, we're looking at the Palm-Cohen system. This is again, which we call as FIGO system 2 of abnormal uterine bleeding, right? We don't need to look too far. We need to look at the Palm-Cohen system, right? So there can be structural causes. Broadly speaking, structural causes would mean that they can be either picked up by ultrasound, so radiologically basically, or there can be some histopath evidence of the structural cause. So they will fall there, right? For example, you'll have these polyps. They can be endometrial polyps, there can be endocervical polyps, adenomyosis can be one structural cause, fibroid, that is leiomyoma, could be one structural cause, malignancy, endometrial malignancy, cervical malignancy could be another cause of abnormal uterine bleeding, right? So like we discussed and we were talking about how prostaglandin imbalance also in the endometrial lining can contribute, and if your endometrial lining is proliferating like in malignancy and hyperplasias, that is also going to lead to excessive abnormal uterine bleeding pattern, right? If there are multiple fibroids, right, occupying the uterine myometrium, and they're distorting the uterine cavity, then we can have a situation where there is this endometrium that is stretched and, thinned out, and then that tends to bleed. Or we have a polyp here, which is, hanging at its pedicle, and this pedicle is, supplied by the blood supply. It could be an endometrial polyp. It could be a fibroid polyp. And then it twists on its pedicle. And then it becomes ischemic. It becomes necrotic, and then it can bleed anytime during the month, leading to the typical presentation of intermenstrual bleeding. So when you understand the concepts, making sense of this Palm-Cohen system becomes very easy, right? And if you look at the non-structural causes, like we discussed that, there should be an intact coagulation system, obviously, to stop a bleeding. So there can be, coagulation disorders. Ovulatory dysfunction is something that I want to talk about a little bit more in detail, and that will touch upon the various concepts that we built earlier also, because this is the most common cause of any pattern of abnormal menstrual bleeding pattern, any pattern of abnormal menstrual bleeding in reproductive age group women, right? This is the first thing that will come to our mind. And then endometrial causes like, for instance, prostaglandin imbalance or endometritis, inflamed endometrial lining, that can also tend to bleed a lot, right? And then we can have iatrogenic if she's on blood thinners, aspirin, warfarin, those kinds, anticoagulant therapy, that can lead to abnormal uterine bleeding patterns. So majorly, we have to focus on these differential diagnosis, so to say. Right? These are the most important differential diagnosis. Now, coming to the anovulatory bleeding. One thing very interesting, we said that in our earlier discussion that cycles are regular because ovulation is a regular timed event. So that means, could we say that if a woman is having regular cycles, 100% does it mean that she is ovulating? Most likely, yes, but not 100%.
Okay.
That's interesting. Most likely, yes. Regular cycles, if a woman is having, most likely she's having ovulatory cycles, but not 100%.
100%.
Okay. However, if a woman says that my cycles are irregular, they tend to come at abnormal intervals, there's no clear prediction pattern. She may have any pattern of irregularity also. She may have regular but short cycles.
Okay.
She may have regular but delayed cycles coming at delayed intervals. She may have episodes of bleeding where she's having prolonged bleeding for days.
Okay.
When she starts bleeding, she gets bleeding for a lot of days, right? And then it stops like that. Or maybe too scanty blood flow also that can happen, right? So very typical of anovulatory bleeding is history of delayed cycles followed by heavy prolonged bleeding. So the history would be something like this, that, sometimes I may bleed in 2 months, sometimes in 3 months, or every 2 months, every 3 months. And whenever I'm bleeding for a lot of days, 10, 15 days like that. And bleeding is also heavy. This is very typical of anovulatory type of bleeding. So if I get this history, I know for sure that she's having anovulatory, she's having anovulatory cycles. Another interesting thing about anovulation is that women tend to have, it's not necessary that all the time she's not ovulating. She may ovulate occasionally in between. And that is why women tend to have, sometimes a span of a time period when the cycles become regular, then they become irregular, right? That can also happen. Now, the common causes that we look, right, one is extremes of age. So one pubertal young girl who's just recently started menstruating, physiologically the system is immature, cycles are physiologically anovulatory. Similarly, in perimenopausal women, right? Again, physiologically, both the extremes of age, we can have this anovulatory pattern of bleeding. Obesity in itself causes. In itself also contributes. See, you have these peripheral fat cells, where androgen get aromatized to estrogen. And what did we discuss? That if there are, chronically elevated levels of estrogen, that would contribute to anovulatory patterns, right? PCOS and androgen excess. So many pointers, during the physiology only I discussed that there can be multiple times you've discussed that when hormonal fluctuations, chronically elevated LH, chronically elevated estrogen levels, elevated or excess androgen levels, they can contribute to anovulation. Thyroid diseases, both kinds, both hypo and hyperthyroidism. But in clinical practice, generally, we tend to see more of hypothyroidism, hyperprolactinemia, excess prolactin, which can also be because of a number of reasons, but it inhibits GnRH. So this is one of the causes of, we mentioned stress, we mentioned excessive weight loss. What we didn't mention was hyperprolactinemia. That also causes hypothalamic pituitary axis suppression.
Stress itself is a cause of hyperprolactinemia.
Yeah, stress is also one of the contributory causes of hyperprolactinemia, right? So one thing can lead to the other. But what doesn't change is the core concept, the basic understanding of physiology of menstrual cycle regulation. And it makes sense of keeping these important 4 or 5 differential diagnoses, the common causes. It is important to keep in mind. Another thing where sir would help me is that whenever you have any clinical condition which is leading to decrease in sex hormone binding globulin levels. So as students who are going to appear for your NEET PG exams, right, this is a very, very important clinical concept to remember. So you can see decreased sex hormone binding globulin levels in obesity. The obesity will contribute to menstrual cycle disturbances by a variety of mechanisms. Okay. So obesity, PCOS, excess androgens, thyroid diseases, all of these also contribute to decreased sex hormone binding globulin levels. So what happens? So we know that sex hormone binding globulin is going to bind to androgens and estrogen in circulation. So if the levels are low, that means free hormone levels, free estrogen and androgen levels are going to increase. And these are the basic hormonal fluctuations they were talking about, and they can interfere with your ovulation, right? So if you remember this much, you remember a lot of different causes. And again, this is what we talk about when we say conceptual building. And lastly, what happens with chronic anovulation? So when we were discussing the physiology, sir had said that you have this progesterone withdrawal
Yes.
bleeding,
Mhm.
right?
Yes.
Because mainly corpus luteum is secreting huge amounts of progesterone, and when corpus luteum dies, there's progesterone withdrawal bleeding.
Yes.
So what happens with chronic anovulation? So we are having multiple follicles growing.
Right.
Maybe there is one dominant follicle, maybe there isn't.
Mhm.
Who knows, right? Maybe there is one, maybe
Mhm.
there isn't. Ultimately, there is no ovulation happening.
Right.
So no corpus luteum.
Mhm.
So no progesterone happening.
Yes.
So the endometrium is exposed to estrogen,
High level.
estrogen for a prolonged duration. No progesterone is coming to rescue the
Yes.
endometrium. No progesterone is coming to stabilize the endometrium, to bring about the secretory changes, right? And the endometrium is just proliferating. Right? This could go on for a month. This could go on for 1.5 months, 2 months, 3
Yes,
months. Who
yes,
knows?
yes, yes.
This could keep going on. And so that is the irregularity that we're talking about, right? And ultimately a time may come that it is going to outgrow its blood supply. And then it gets shed off. That's one thing that happens. The other thing is what happens to these follicles that were growing but did
Yes.
not get a chance to become a dominant
Ovulate,
follicle.
yeah.
Maybe it became a dominant follicle but did not ovulate.
Ovulate.
So
Yes.
its journey was cut short. Ultimately they're going to die.
Yes.
So these follicles, they will not keep growing forever.
Ah,
So they will have follicular atresia. Now these were the follicles that were producing estrogen.
estrogen. Yes.
So now there is estrogen withdrawal.
Okay.
So what we see here with chronic anovulation is A, the endometrium is exposed to continuous proliferative effects of estrogen. And when the withdrawal bleeding happens, this is estrogen withdrawal bleeding.
Mhm.
This is not bleeding from a stabilized endometrium under progesterone
Progesterone,
influence.
No.
This is estrogen withdrawal bleeding. It generally tends to be prolonged and heavy.
Okay.
So this is why we can get, any pattern of abnormal menstrual bleeding pattern, irregular cycle, short cycle, delayed cycles, heavy bleeding, prolonged in duration or heavy in amount. Those sorts of bleeding patterns are very common with chronic anovulation. And the other concept, progesterone was having such a, nice secretory effect on the endometrial lining, and it was also stabilizing the endometrium because it downregulates estrogen receptors on the endometrium, right? So you understand here one more thing. We said, sir, that in the second half of the cycle, that is the luteal phase, right? Corpus luteum is secreting both progesterone and estrogen a little bit, right?
Yeah.
But the effect on the endometrium is more of progestational.
Yes.
That's because progesterone is down-regulating estrogen receptors. It's not just that estrogen is being secreted in less amounts, but also now the endometrium will not really respond to that estrogen much. It will mainly be a progestational influence on the endometrial lining.
So although the estrogen is there, little amount, but that effect will not that be stronger like that.
Yes, it will be
proliferative
mainly
phase,
progestational effect on the endometrial lining. This is the concept. The clinical correlation is if there's prolonged history of chronic anovulation, repeatedly it is happening, okay? Again and again this is happening. It's a risk factor for endometrial hyperplasia and cancer. Right? And the other clinical correlation is so many places you will read now, progesterone has a role in management of abnormal uterine bleeding, and we use progesterone therapy also when we're talking about treatment of endometrial hyperplasia. Right? So these are the two basic clinical correlations when we talk about abnormal uterine bleeding patterns. And when you keep these clinical correlations in mind, right, understanding the hormonal aspects of gynecology. As an undergraduate student, I also used to find endocrinology the toughest part in, gynae. But it is only by repeatedly going back to the menstrual cycle, the details, the smaller details which you tend to miss out, right? It is only when you understand the physiology is when you can make sense of the pathology, right? Isn't it? So we will end the session, and I would like to say thank you. Sir, would you like to add something?
Also. That's all, I think. So please try to remember this concept. Okay. Thank you so much.
Thanks a lot.